close contacts were subjected to strict institutional quarantine and were subjected to PCR testing on arrival, and all of them were institutional quarantine for 14 days, and at the end of the quarantine period, they were again subject to the exit PCR before release to the. Both symptomatic and asymptomatic COVID patients were provided with mandatory institutional care. So asymptomatic patients were managed at the intermediate treatment center, but all subjects with symptoms were managed at the specialized centers. The regular screening of high-risk populations were identified based on the epidemiological evidence. All the subjects with signs and symptoms suggestive of COVID admitted to the isolation units and subject to the antigen or PCR testing. Then 1% of the employees were regularly subjected to the PCR testing as a screening at the large establishments. Then the initial stage, country adopted in the first wave, country has adopted the countrywide lockdown to contain that. But the subsequent waves, I think we managed without lockdown in the whole country. Lockdown is limited to the small geographical locations where extensive transmission is reported. But all these lockdown decisions were purely taken based on the epidemiological evidence. That way, the country was able to manage without minimum interference to the other to the economic purposes. Then all massive public awareness on preventive measures were done and adopt selected strategies to discourage border crossing time to time adopted. Then recently we started with the help of Indian government. Country was able to start the vaccination. Targeted vaccination started with COVID vaccine in the latter part of January because we gave the donation from the Indian government. Thanks to that, country was able to buy now vaccinated all our health staff, including the attached to curative sector, public health sector, and the private sector with the first dose of COVID vaccine were given. We have now vaccinated more than 300,000 without any single serious adverse events reported during this whole exercise. When we consider the enabling factors which help us to carry out these effective COVID control measures in the country, one is that having well-established, time-tested public health infrastructure covering all country, in high standards of curative and laboratory services and free health service with equitable access. That way we were able to provide health facilities to all the citizens without any fee, even a transport, and not only the treatment facilities, even the transportation and everything is provided free of charge by the government. Then prevention, other thing is the Prevention and Quarantine of Disease Ordinance. This was nearly 100 years old Quarantine Act, which provides us the legal basis for to carry out all the preventive measures related to the COVID control and prevention. Then health-seeking behavior of the public and high level of government commitment and close collaboration between the health sector and the military sector in active contact tracing and maintenance of the quarantine centers and evidence-based decision-making were the identified enabling factors for us to achieve. Thank you.
Thank you, Excellencies, ladies and gentlemen. With your collective permission, I would now present the experience of India in tackling the pandemic. Distinguished colleagues, it's truly an honor for me to be sharing India's COVID-19 management experience with you. As of date, when we look at the global scenario and we compare cases per million and deaths per million, we find that India has done quite well. This has been possible because of the highest level of commitment as well as a timely and prompt institutional response. Since the onset of the pandemic, India has followed a whole of the government and whole of society society approach in a proactive, preemptive, and graded manner with strong political will and a decisive leadership. India initiated its response towards COVID-19 by 8th of January 2020 when we set up a joint monitoring group under the Director General Health Services, although the first case in India was reported much later on 30th of January 2020. Being a federal political setup, our response has been in close collaboration with all state governments. We have brought all stakeholders, most importantly the community, on one platform towards a single goal, which is to minimize the impact of the pandemic. We have worked to strengthen our core capacities which were needed to face the situation. Our response initially was focused on heightened surveillance at the points of entry, for example, airports, land borders, and seaports. We also issued requisite travel advisories. This was followed by surveillance in the community through our integrated disease surveillance network, which is an IT-enabled network that we have developed over a period of time. We started active screening and isolation of travelers as early as 18th January, which is 12 days before the first case was reported in our country. Based on the evolving scenario of the pandemic, we imposed a partial lockdown on 22nd March and subsequently we went in for a complete lockdown on 25th of March 2020. This decision of a lockdown helped us in preventing the spread of infection across the country and also prevented thousands of cases and deaths that would have happened. We maintained a continued focus on test, treat, and track approach towards COVID-19 management, which has yielded very good results. We utilized the lockdown period to create a dedicated COVID-19 clinical management framework. We created COVID care centers, COVID health centers, COVID dedicated hospitals. These facilities provided isolation beds, oxygen supported beds, and ICU beds with ventilatory support. We increased the number of our isolation beds by more than 1.5 million. We increased our oxygen supported beds by 0.25 million. And we provided 80,000 ICU beds as well as 40,000 ventilators. So all this was done in a record period of time. We also created makeshift temporary hospital facilities which enabled us to avert overwhelming of our existing healthcare apparatus. We kept in mind Honorable Prime Minister's vision of self-sufficiency or Atmanirbharta. This led us to enhance our indigenous manufacturing capacities, and we not only created but strengthened our domestic production capacities for diagnostic kits, for personal protection equipments, for ventilators, and other associated equipments. Our indigenous manufacturing capacity not only benefited our own people, but it benefited other nations as well. We supported more than 150 countries by supplying essential medicine, including hydroxychloroquine. We became, during last year, a net exporter of PPEs, N95 masks, and ventilators. We ramped up our testing and diagnostic capacities. We had one lab in January 2020. Today, our lab network has 2,238 labs. So that's a quantum jump. We also do more than 1.5 million tests a day. Clinical management protocol was finalized and it was disseminated so that we could bring down the fatality rate. An integral element of our response strategy was rapid upskilling and capacity building of thousands of our healthcare and frontline workers. We created digital online training module and we oriented 16 million strong army of COVID warriors using these digital tools. Active involvement of community has been a mainstay of India's COVID management approach. We have also focused on effective use of print, electronic and social media. Without an effective therapeutic intervention, the triad of precautions, that is use of mask, hand hygiene and physical distancing, were used across the country as social vaccine, and it is now that we also have actual vaccine in place. We also leveraged IT and data analytics since early stage of the pandemic to support COVID management efforts. For active surveillance and contact tracing, we developed a mobile app called Arogya Setu, which quickly became one of the most downloaded apps in the world. This enabled us to quickly identify evolving hotspots and then contain the spread of infection in those potential hotspots. We also developed a COVID-19 India portal, which is a comprehensive centralized surveillance online portal which gives us real-time data as the disease progresses. We have utilized telemedicine and e-ICU tools to ensure continuity of services during these challenging times. Even the vaccine delivery today in our country is being monitored through CoWIN. CoWIN stands for Winning Over COVID. This is an IT platform to monitor end-to-end vaccine logistics and delivery. At this stage of the pandemic, efforts of India's research institutions and our vast vaccine production capacity has resulted in India kick-starting its vaccination drive since 16th of January. We have given emergency use authorization to 2 vaccines which are manufactured in the country, Covishield and Covaxin. As in the case of other logistics and medicine supplies, we are extending essential vaccine supplies not only to our own citizens but also to other countries as a responsible global partner. So far, India has supported more than 24 countries with vaccine supplies. Now, as we gradually come closer to normalcy and economic recovery, we must continue to remain cautious and vigilant. Going ahead, we will keep our focus on test, track and treat strategy. We will ensure community involvement and promotion of COVID appropriate behavior, and we will ensure timely and prompt vaccination of priority population groups. I thank you for your attention. Excellencies, ladies and gentlemen, we are privileged. We have been joined by Union Health and Family Welfare Minister, Dr. Vardhan. Before I invite Honorable Dr. Vardhan to share his closing remarks, I would like to bring to the Honorable Minister's notice that the session has been mutually beneficial and fruitful for all of us. This workshop has witnessed rich contributions from our fellow nation states who have showcased the best practices adopted in the fight against the pandemic. What this experience sharing has underlined is the fact that globally we are only as strong as the weakest link in the health security chain. Therefore, it is necessary that collaboration and investment in international and regional cooperation mechanisms and health systems is essential. India would like to reiterate our commitment towards a better healthcare landscape for all, and we look forward knowledge sharing and renewed collaboration. With these remarks, I would now request Honorable Union Minister for Health and Family Welfare, Government of India, Dr. Shri Vardhan, to kindly address us. Dr. Vardhan, please.
Dear friends and colleagues, I thank you all for your enthusiastic participation in this workshop on COVID-19 management and its challenges, where you have shared your experiences, good practices, and the way forward. I feel privileged to be addressing all of you, as you are all dedicated and dynamic leaders and drivers of public health from across 10 nations. Friends, we have all discussed how the pandemic has made humanity acutely aware of the consequences of ignoring the strengthening and preparedness of our healthcare systems. It has taught us that in such times of global crisis, both risk management and mitigation require further strengthening of global partnerships to revitalize interest and investment in global public health, which is exactly why we are all here today discussing further global solidarity. Friends, Honorable Prime Minister Shri Narendra Modi ji has spoken at length about how India was amongst the first nations to gauge the impending danger and initiate a lightning response. Under his able leadership, we acted with scale and determination to tackle the challenges. Despite many constraints, India managed to keep its cases per million as well as the number of deaths at figures that were lowest across the world. And we are continuously showing a reduction in these numbers. The strength of India was that it adopted a whole of government and whole of society approach. A nation of 1.35 billion people exhibited the strength and determination to diligently follow the stringent containment guidelines imposed by the government. The whole nation came together to follow its leader, Honorable Prime Minister Modi ji, who showed the political will to take unprecedented and strong steps to contain the pandemic. Today, India stands at another threshold of vaccinating each and every Indian against this dreaded disease. We have commenced the world's largest vaccination drive, and I am proud to say that to date, India has managed to vaccinate more than 9 million people. We are now looking towards a speedy and prudent return to normalcy, whilst undertaking strategies to balance both the health and economic stability of the country. I take this opportunity to reiterate that India was blessed to have great leadership guiding us through this economic crisis. Led by Modi ji, we turned this challenge into an opportunity. In fact, the crisis became a harbinger of a paradigm shift via liberalization, privatization, and globalization. Friends, I have called 2020 the year of science, when the best of humanity has shone through the gloom that descended upon us. Major global collaborations were set up so that scientists could share their expertise. While we applaud science, I must also say that it's not just the science that has been remarkable. The biggest success of this pandemic has been the teamwork and people putting the right outcome ahead of individual glory. Scientists and organizations actually focused on delivering a meaningful goal, whether it was across a nation or across a continent or across the world. Friends, India as a nation is already providing thought leadership to the entire world in the sphere of public health, engaging in partnerships where joint action is needed, shaping the research agenda, and stimulating the dissemination of valuable knowledge. We believe in the principle that the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic or social condition. Our unique initiative of Vaccine Maitri, which means vaccine friendship, was launched because India's foreign policy is governed by its age-old maxim of Vasudhaiv Kutumbakam, the word is one family. When the world faced a crisis of confidence regarding the shortage of diagnostics and vaccines, Prime Minister Modi ji affirmed that India's production capacity will be used to help humanity in fighting the virus. The humane and caring attitude of India, led by Prime Minister Modi ji, is being appreciated by the entire world. It is evident that India wants peace, security, cooperation, and prosperity in the world. Friends, the pandemic has taught us that all such health emergencies demand a shared response, because these are shared threats requiring shared responsibility to act. In fact, what is the greatest need of the hour is a greater degree of shared idealism of nations. I thank all of you once again for participating in this workshop and charting out a bright future for the world through mutual cooperation and solidarity. Thank you and Jai Hind.
Thank you, Honorable Minister. Now I would like to propose a vote of thanks, sir.
in the town of Goke in the southeast of the country. 50 contacts have been identified in Guinea and 368 in the DRC and are being monitored. Vaccinations are already underway in the DRC, and we expect the first shipment of vaccines to arrive in Guinea this Sunday. The outbreaks in Guinea and the Democratic Republic of the Congo are completely unrelated, but we face similar challenges in both. Both outbreaks are occurring in areas that have recent experience with Ebola and are benefiting from the experience in terms of capacity for surveillance, rapid response, contact tracing, community engagement, clinical care, and more. But both outbreaks are also in hard-to-reach, insecure areas with some mistrust of outsiders. WHO is working closely with health authorities in both countries to engage with the affected communities to enhance trust and acceptance, and we will keep you updated. Ebola and COVID-19 are two very different diseases. Both thrive on misinformation and mistrust, but both can be stopped with proven public health measures, engaged communities, accurate information, and vaccines. Thank you once again to all member states for your support and engagement. We look forward to that continued support and engagement in the coming weeks and months as we work together to respond, recover, and build. I thank you. Back to you, Jude.
Thank you very much, Dr. Tedros. We would proceed now to our next agenda item on COVID-19 strategic and operational update, and I shall invite Dr. Mike Ryan, Executive Director, Health Emergency Preparedness and Response, to open this agenda item. Thank you.
Hi. Thanks very much, Jude. Thank you, G. Very briefly, Scott Prendergast is online and will make a presentation just outlining the contents of the strategic plan. I would like to thank him also on behalf of Jane Ellison, our Executive Director on External Relations. Thank you all for the support, and on behalf of the DG, obviously, thank you all for the support that you've given to the last SPRP last year. It was vital. It made a huge difference to WHO's capacity to support our member states with the technical, scientific, operational, and commodity items needed to fight the first year of this pandemic. And we thank you for that. There is a report that will be coming out in the coming days on last year's experience, looking back at a year that changed the world, and it will be interesting for you to see and reflect on all of the work we have done together. And again, I state that WHO's work in support of our member states is only ever successful when we're working in partnership with the rest of our collaborating centres, our networks, our UN partners, our INGO and other partners. WHO leverages the best minds, best organisations in the world to serve our member states and your peoples. The plan for this year is larger than the plan for last year in financial terms, but it incorporates huge new pillars around delivery on vaccination and the work that Kate O'Brien and the team are leading in delivering vaccines at country level and at subnational level with our colleagues in UNICEF and CEPI and others in the COVAX initiative. It also obviously includes the ongoing technical and operational support to countries, and also beginning to build some of the longer term systems we're going to need to maintain control over this disease in the future, and the architecture we're going to need to prevent the next pandemic and respond to it more effectively. So with advanced thank yous to those of you who will, I hope, consider this plan within your current funding cycle. I just wonder, Jane, if you have anything you'd like to say at this point. We'll go to Scott. So Jane, myself, and the others here will be available to take any of your questions. Scott, you have the floor.
Thank you, Mike, and thank you. Presentations coming up. So in 2020, the Strategic Preparedness and Response Plan was the global strategy for preparedness and response to COVID. Along with it, there was a number of other guidance documents, including the country-level operational planning guidelines. We had a strategy update. We also had the monitoring and evaluation framework with the objectives of suppressing transmission, protecting the vulnerable, and saving lives. Next slide, please. The SPRP for WHO was our major funding and implementation instrument. There was a $1.7 billion budget, and thanks to the hugely generous support from all member states, we raised $1.58 billion, of which we implemented during the 2020 period $1.3 billion. Some of the money was specified for 2021. More than 90% of those resources went to country and regional level to support member states and work with partners to prepare for and respond to COVID. We also had a large program within that, in particular to the global humanitarian response countries, where with $580 million going through to those countries where WHO provides a much more extended operational support. Next slide, please. The SPRP was used as the centerpiece in terms of country action. Many national action plans in about 144 countries were developed based on the pillars under the SPRP. We also had in a number of countries the partners and the governments coming together with governments in the center of that to plan for COVID under the partners portal, where all partners could be putting their resource requirements, and donors would have full visibility of what those resource requests were, where the critical gaps were. So beyond just even WHO program implementation, the SPRP was very much a centerpiece of the preparedness response. Partners platform, the supply portal, enabling all countries to have access to essential supplies such as diagnostics, PPE, oxygen, ventilation. Next slide, please. The SPRP drove critical partnerships very much across the UN under the UN Crisis Management Team, with all UN agencies coming in under the SPRP, and also other critical partnerships such as the ACT Accelerator to accelerate the access to new and very needed COVID tools. Next slide, please. The strategic objectives for 2021 are based on the lessons learned coming out of 2020 and are covered under suppressing transmission, reducing exposure, countering misinformation and disinformation, protecting the vulnerable, reducing mortality and morbidity, and accelerating the equitable access to the new COVID tools. And these objectives are really driving all of the different pillars of the response towards the goal of preparing for and responding to COVID. Next slide, please. For 2021, the scope of the SPRP covers the continued preparedness and response to COVID globally. It also covers the need to accelerate the equitable access to COVID tools, not just the upstream discovery, development, scale up and scale up, but also now increasingly the downstream delivery of those tools. It also covers the underpinning of the need for maintaining essential health services and strengthening health systems for health security. This is being done in the context of the broader general program of work of WHO under the triple billions. Much of WHO's work has been reprioritized, reprogrammed towards responding to COVID, but at the same time, we're still delivering against the promise of the triple billion. We're also integrating with broader humanitarian and development and recovery programs, such as the humanitarian response plans and the socioeconomic response and recovery plans led under the UN teams. Next slide, please. These coordinated strategies are coming in under a number of coordinated structures. that we work across the IAC, the UN Crisis Management Team, together with the ACT Accelerator to ensure these plans and strategies are aligned and talking to each other. So we've got very strong management structures which are on a day-to-day basis, both at the global, regional and country level, driving the coordination of this response in support of national authorities to prepare for and respond to COVID. Next slide, please. In terms of our own operations, these are integrated under a number of cross-cutting pillars of the response, including risk communication, surveillance, points of entry, laboratories and diagnostics, infection prevention and control, protecting health workers, case management therapeutics, maintaining essential health services and systems, operations support and logistics, coordination, planning, financing and monitoring, and research and innovation. To these pillars, we've now added under 2021 the very important vaccination pillar. And in fact, many of the country-level vaccination plans have now been added to the Partners Portal as Pillar 10 and are being coordinated jointly with governments, with the World Bank, with UNICEF, Gavi, the WHO and other partners. Next slide, please. In terms of WHO, the SPRP is the main way that we're translating knowledge into action. So in terms of WHO's work under the SPRP, leveraging international expertise, to providing authoritative, accessible, evidence-based guidance, to then working at country level and regional level to support the implementation and operations, and then to monitoring, evaluation and learning, to then adjust the strategies and evidence as the COVID outbreak or the COVID pandemic changes over time. This is underpinned by our ongoing work in terms of epidemiological intelligence, including tracking of variants, as well as our operational intelligence, looking at what's actually being implemented and where are the gaps. Next slide, please. The overall resource requirements for 2021 are 1.96 billion. This represents an increase over the actual operations of 2020, but it reflects the fact that WHO now has in place all of our operational structures at the country, regional and global level, which we can continue to build from, as well as the need to further scale our operations to introduce and support the introduction of the new COVID tools, not least of which is the vaccines. Next slide, please. The budget is broken down by the pillars that I mentioned before. It's also broken down by our regions and countries. So we're able to provide detailed breakdowns of what the actual resource requirements are. These requirements have been developed together with countries and partners at the country and regional and global level, and reflect the work that WHO is being requested to continue to support for COVID preparedness and response. Next slide, please. The budget is fully integrated with the humanitarian countries where there's global health clusters and global humanitarian response plans. So within those countries, there's a need of 643 million, which is fully contained within the 1.96 billion requested under the SPRP. So this reflects the COVID dimension of those humanitarian responses. Next slide, please. The budget's also fully integrated with the Act A budget, where it represents WHO's contribution to the core Act A budget. And so we're able to then crosswalk between the SPRP 1.96 billion budget to the 1.2 billion budget of WHO contained within the Act core budget under vaccines, diagnostics, therapeutics, and health systems connector. Next slide, please. Whilst the 2021 needs are represented at 1.96 billion, we have an immediate set of needs of 167 million to get just through to the end of June. So with our current operations running, we are currently fully operational and have an immediate cash need of 167 million, against which we have available 40 million of core flexible funding for COVID, leaving approximately 130 million. So there is some urgency to continue to mobilize resources to continue to serve countries. Thank you, and back to you, Mike.
Thank you, Scott. And I think we're going to proceed with the next presentation. We'll take questions together. I'm joined here today by Paul Molinaro, our head of operations, support and logistics, and we're very pleased to welcome Chanel Hall and her team at Yellow House. Chanel is ex-of supply division in UNICEF, but has worked with her team to review our work within the UN supply chain task force and the work of the supply chain platform that was brought together to address many of the issues we faced. The pandemic delivered the biggest shock to global trade since World War II, and the collapse of many of the market mechanisms for the commodities that we needed right at the time when we needed them, like PPE, medical supplies such as oxygen concentrators, respirators, laboratory reagents, test kits, etc., etc. The breakdown of that normal market functioning for essential response commodities posed a huge challenge for effective delivery at national and global level. Our promises to people regarding clinical care, infection prevention and control, lab testing, and the safeguarding of essential health services. The work that has been done in the beginning, bringing together WHO, UNICEF and WFP, the public and the private sector, how that evolved into the supply chain task force and the UN supply chain platform is something that Chanel and her team have been looking at independently and looking for those lessons learned, both in terms of how we improve the system in the short term, but also how we look to the future. I'll just ask Paul if there are any other introductory remarks you'd like to make before we give the floor to Chanel.
Thanks, Mike. What we'll go through is very briefly the key highlights and lessons learned. It's a culmination of about 3-4 months of work. We had decided around October through the UN supply chain system, the task force, to conduct this outside-in review, to take lessons from this, both in terms of going forward in the current event, but was also really looking at how would we set up as a response community for future events of this size. We are in the final stages of putting together the report, and a version of which will be most likely made public. So without further ado, I think it's to present Chanel, the work her team has done, just to give key lessons and recommendations going forward. Thank you.
Chanel, you have the floor.
Super, thank you. Tedros, am I sharing the screen myself?
No, we will share from here.
So as mentioned, we have had we'll go ahead and start sharing.
Just give us a few seconds, we will get onto it. No, you speak to it, we will share it.
Honor and pleasure of really looking back at what the UN and civil society and other global health partners did in terms of helping countries have access to these life-saving and essential COVID supplies. Go ahead for the next slide. The assessment sought out to answer these questions in the yellow box. Basically, how did it help improve access? As mentioned, it's really kind of a semi-independent assessment. We had an independent advisory group comprised of civil society, foundations, and UN partners. We have had some discussions with the independent panel, the IPPBR, and they are looking to use this, the output of this analysis, as one of their inputs. Next slide. So what happened? This is a snapshot of all that the mechanism undertook in 2020. You can see that partners delivered just over 1 billion supplies for 184 countries, the details of which are summarized at the bottom line. 43% of that spend or the amount was for PPE, similarly for diagnostics, and then 14% was biomedical. You can see large volumes in summary were supplied. And interesting, if you look at the number of oxygen concentrators, it really was an opportunity to help countries build out their medical oxygen needs, which is something that's being continued. As mentioned by Mike, this was a period where there was major supply constraints, so probably these were not enough volumes, we know that, but it was impressive to see all that was secured, given that really there was global competition to access the same markets. In the early months, all of it was delivered by air, and then over time, that started to move to less cost expensive means, but you'll see in a minute that there was no month when the system couldn't deliver to countries. Next slide, please. In the survey, we asked countries what were their channels of accessing these life-saving supplies, and this is a summary of what they showed by different product group. And you can see, on average, countries use this mechanism to access about half of their supplies, which was important to understand. And also you'll see in some of the recommendations that they still used other channels, up to a third went to markets directly. And that speaks why they also want visibility on what global market situations are, so to help them better access even when they're approaching the market directly. Next, please. This is where those supplies were distributed to, so on a regional basis. This is value. If we looked at the quantities, it's a similar portion. So you can see the largest amount of supplies in terms of value went to Afro, and then continuing on down. And you can see the groupings based on what the purchasing consortiums represented, but basically IPC, clinical care, and testing. Next slide, please. This shows the number of deliveries that the mechanism made each month. As mentioned, well, you can see there was a lot of deliveries already starting in January, but in February and March, it was one of the strengths of the mechanism, the very rapid response to give countries a minimal initial volume of PPE and testing supplies. In April and May were some of the tightest months on the beginning of the collapse of markets, as was mentioned, but nonetheless, deliveries were still maintained, and civil society referred to the mechanism as a game changer, since they on their own would not have been able to contribute to countries' humanitarian response. And overall, there was really no point throughout the year when supplies of all sorts were not able to be distributed or moved between countries. Next slide, please. This is a snapshot summary of what worked well. The early signals to markets made by WHO were very powerful. So very early on, they warned of shortages of PPE, also made projections. There was the rapid deployment of supplies and funding, which went to over 110 countries, which was super impressive. And we could see the preparations that were put in place post-Ebola and also pandemic influenza planning that really contributed to a successful early rapid response. We also think the initial strategy of this mechanism and the early coordination that was put in place was very powerful. I think you heard in the last presentation from Scott some of the planning tools that were put in place to help with visibility, help with coordination, and execution. There are some weak points of that as well, which are mentioned in the moving forward. But the fact that we hadn't seen that type of integrated system that was made online for really all partners to access. I mentioned the delivery, and maybe the last thing here is just that this mechanism really accessed all of the assets of the UN and partners in terms of health procurement and their influence with markets. We call it a multi-lane approach, and what we saw was that by breathing air into the assets of partners rather than stifling and kind of forcing everyone to work through one or two partners, that really did increase access. The weak part of that, or the challenge of that, is the need for coordination, which if you move to the next slide, we think that in terms of what were the lessons learned that partners themselves said have been better, one of them is in fact coordination. We also talk about the importance of having this continue to be pandemic response led, and that certainly accessing markets, the authority that the pandemic response leadership brings to the market is certainly important to continue to bring to bear even at the later stages of the later phases of the pandemic. We think that one of the challenges was to build some of these tools and systems in the middle of an outbreak, so it's better to establish a playbook to define roles, a system to coordinate, etc., and build that in peacetime with countries, with partners, with the World Bank, NGOs, etc. One of the things that the regions and countries asked is that they be more included in the upfront design of it, and that their regional and local procurement mechanisms be a part of it. And so we think that's an important lessons learned. Obviously, the importance of data. Data fuels the supply chain and obviously helps with strategic decision making and knowledge of how innovations are being used, etc. So a lot of lessons learned on data. Execution leadership. I think we've seen this through humanitarian responses, the importance of having a firewall between coordination and implementation, maintaining a strategic overview, etc. Not to go into the details, but obviously this was a massive together. Foundations, NGOs, etc. On financing, we could see that so much of the financing for countries came to the World Bank, and while they were engaged originally, we think tighter coordination is really important. Also, the importance of the kind of the fast capital, that bridge funding and potential volume guarantees provided in terms of enabling access to markets early was super important. And then really taking a market-tailored approach to access. So the way that a consortium would approach the PPE market, which is more of a commodity-based with scale of production, is different than how you would approach a pathogen-specific market where they're innovating products such as in tests or even vaccines, where the manufacturers themselves have heavy influence on who gets access to those products. And so strategies to maximize access regardless of market type, we think is a very important component moving forward. Next slide. This just shows when we did the survey that overwhelmingly the majority of survey respondents felt that this mechanism was important and something like this needed to be continued for the next phase of the pandemic response and for future health emergencies. Next slide. This is a snapshot summary of lessons learned of the different components of the CSCS. We don't have time to go through this, but just to show that we looked at each of the key access components and come up with some lessons learned based on what worked well and better it. Next slide, please. And I think this is the one that was concluding. And basically, if we look at the response in phases, that obviously it would be good to learn from this and establish a playbook that would define roles and responsibilities, so that some of those tensions that get created or that occur in the early stage are set aside because you've taken those decisions up front. Building your data needs and systems also during peacetime is much better. That should be done with countries, regions, the banks, etc. And then when on the onset of a pandemic or a large epidemic, that then you're focused on providing 2 to 3 months of rapid response cushion through a combination of regional, country, and global. And at that point is also when you're adapting the playbook to respond to whatever the pathogen is and its scope, etc., and reconfirming roles. And then after those first 2 to 3 months, you're really focused on maximizing access and with WHO providing leadership on the global response that really, again, is empowering and infusing the assets that exist between regions, countries, partners, etc. We put a couple of key components on it, obviously making sure that it's grounded in country needs that there's a coordination so that countries aren't met with many different bits and pieces, but a coordinated regional and global support, and potentially looking at what support might be needed on in-country distribution and logistics. And then this recommendation on helping countries and regions have better visibility on global market situations. And each of these recommendations builds on something that WHO with partners are already working on. So we think it's the WHO and partners are well positioned for the next phase in preparing. And I think that concludes let's go to the next slide. I think that concludes it. So thank you.
Thank you, Shannon. I'd like to thank you personally and all your colleagues at Yellow House for your work with all of the partners to carry out this review. And just to remind member states that I believe, the actual report will be out next week, and I know there's a very much more detailed slides that accompany with it, but I'm sure member states would really like to go through that. Finally, would like the emergencies program has been a big part of this, but without our colleagues in business operations, particularly Raoul Thomas and all his staff in procurement, and Raoul has been an equal partner with Paul and associate and others in driving this forward. And just a note of thanks to yourself, Dr. Tedros. Go back to last January, February, and writing those, picking up the phone and writing those letters to the manufacturers at that time, and to member states hosting the large manufacturers, pointing out to them that this was going to be a major problem, allowed us to exit the market on behalf of member states in a much more effective way. So we had to build this ship while we sailed it. We had been, for a number of years, trying to establish the concept of a pandemic supply chain network, PPSN, you remember? Finding it exceptionally hard to get it funded, and exceptionally hard to get bandwidth from partners about how important this was. I hope this experience has now allowed us the opportunity in tragedy to develop the systems that we actually need, and we look forward to taking the next steps on that with you. Back to you, Jim.
Thank you very much, Mike, for facilitating the presentations for this important agenda item. As I indicated earlier, we'll open the floor for a set of round of questions. In the interest of time, I would humbly entreat our delegation to be brief in their questions, and also the Secretary to be even more brief in your response so we can proceed to the other items for today. So with that said, I'll pass the floor to our moderator, Ms. Ferdia Longquist. You have the floor, ma'am.
Thank you very much, Chair. Once again, those wishing to take the floor, I would kindly ask that you raise your hand in the Zoom platform. With that, I should wish to give the floor to the United Kingdom, to be followed by the Netherlands and then Germany. UK, you have the floor.
Thank you. On the presentation setting out the SPRP, the UK is really proud to be a founding donor to ACT-A and has made commitments to the ACT-A up to £830 million. And we also continue to be the biggest flexible funder to the WHO through our £340 million core voluntary contribution. My questions relate to the really, really helpful presentation just now on logistical planning. As you say, learning the lessons is absolutely critical, not least as we expect the logistical challenges to get even greater as we roll through this year and into 2022. And given it's so critical that we learn the lessons so we strengthen rollout of vaccines, particularly on the logistical planning, getting vaccines out to communities. Thanks.
Thank you very much. And now to the Netherlands, to be followed by Germany.
I just want to say a tremendous thank you to the team and the people and the organizations having worked so incredibly hard and worked so well together in this incredible last year. So with such great results, and I'm very happy to see this. We in the Netherlands Parliament, we will discuss the request to support the 2021 SPRP. What is commendable is that you have integrated different needs in humanitarian settings, maintaining health services, and the needs in the different pillars of Act A. We are at the moment in a caretaking government. We will need some time to discuss this. And in the meantime, we hope that our contribution to the Central Fund of Emergencies will be of use as well to carry this SPRP forward. Thank you.
Thank you very much. And now to Germany, to be followed by Zambia.
Thank you, moderator. Thanks so much. I want to reiterate, of course, the thanks just expressed by my Dutch colleague to the tremendous work. Thanks so much for explaining especially the intersections of the SPRP and the ACT Accelerator. And happy to see there is such a big overlap, in fact, to the extent how the SPRP contributes to ACT objectives. This, in a sense, is a win-win situation for donors because contributing money basically means contributing to both sets of objectives. And it's especially helpful for Germany at this moment because we are looking at the moment at fixing our new contribution to the ACT Accelerator for 2021, which will be a significant increase, probably around almost tripling of the contributions from last year, from 600 million to something beyond 1.5 billion for 2021. And this, it's important to note, comes in addition to what we're doing at the moment, because of course we may not forget over COVID-19 all the other important work that is being done, the other emergencies. We see the Ebola outbreaks at the moment, the continuation of essential services. So it's really key that this work continue, and this is why we will remain committed to contributing, for example, to the CFE and other objectives at the same time. Thank you also for these very interesting lessons learned on the supply chain system. This, we think, is key not only for the current response, but also for the future, and in the context of the whole discussion around strengthening WHO and possible reforms, especially when it comes to the key leadership and coordinating role of WHO. So thank you very much for these elements, and I'm happy to share these with our experts at capital level. And lastly, of course, this also speaks to the difficulty when responding to a pandemic like COVID-19 to balance travel and trade restrictions. We see the difficulties in supplies, so this will also be something to take care of in our discussions around reform and how to continuously adapt our response. Thank you very much.
Thank you. And now to Zambia, to be followed by the United States of America.
Thank you, Chair. And thank you, DG and Secretariat, for sharing this very important information, particularly the insights into the SPRP 2021. However, as uncertainties around vaccine supply to much of the developing world remain, there are complex questions on liabilities awaiting downstream of this massive global vaccination exercise. You have informed us that the yet unseen challenges on fixing liability issues have been addressed in the form of a no-fault compensation fund that will pay for claims arising out of the introduction of vaccines in the developing world. We would like to know whether this cost is covered in the SPRP 2021, and if not, Zambia would like to ask the basic questions. Who will cover the costs? How and what could one expect in the future? And secondly, we also would like you to shed some more light on how changing market dynamics in the COVID-19 vaccine business could influence claims liability and indemnification provisions in the coming months. Thank you, Chair.
Thank you very much. And now to the United States of America, to be followed by Canada. USA, you have the floor.
Thank you, Flavia. Apologies for the delay in unmuting, and I know that we're operating on a very tight time frame, so I will try to speak quickly, but at a pace that allows for interpretation. I think first, wanted to just thank the team across WHO that's worked on the SPRP and the Partners Platform for the last year. A year ago, you were taking up and continuing a very complex Ebola outbreak in DRC when we started all of this innovation. And I know that you're now doing double duty and triple duty again. And so want to acknowledge the work that you're doing. We, like others, really appreciated the clarity in this SPRP for 2021, particularly being able to really map WHO's work through that day and really the clarity in the humanitarian settings. We will study it closely and be able to come back to you about how we might be able to help support. I think also, like others, the supply chain review findings and recommendations are small, and we actually would love and look forward to those slides. To the DG, thank you very much for the Ebola updates. We look forward to working with WHO on this response, both in DRC and West Africa. Just on a broader funding topic for WHO, we thought it would be helpful to update member states and WHO that by the end of the month, the United States intends to pay over $200 million in assessed and current obligations to the WHO. The Secretary of State, Blinken, stated yesterday that this is a key step forward in fulfilling our financial obligation as a WHO member, and it reflects our renewed commitment to ensuring the WHO has the support it needs to lead the global response to the pandemic, even as we work to reform it in the future. And so we look forward to working with WHO on these details as we learn more about them. And then finally, if I could just ask for an update from Mike or others just on the projected release of the Origin Summary Report. Thank you very much. I really appreciate the briefing today.
Thank you very much. And now to Canada, to be followed by Palestine. Canada, you have the floor.
Thank you very much for those two helpful presentations. On the SPRP, Canada was pleased to be a donor in 2020, and we are pleased to be working with you on some new investments for SPRP 21 and ACT, and as well for primary health care and strengthening the linkages between those two things. So we're really happy to see as well that in the SPRP really integrated the ACT work in there very clearly. For 2021, Scott, you mentioned that it was built off of the lessons learned from SPRP implementation in 2020. I'm wondering if you could speak briefly to what are some of those key lessons learned, particularly from a WHO operational perspective, scaling up an operations that size, and what you're going to be taking forward in 2021 to address some of those lessons. Thanks very much.
Thank you. And now Palestine, you have the floor.
Thank you very much, moderator. I'd also like to thank all of the speakers for the presentations that they've made. And I'd like to thank the entire WHO team would like to thank all of you for the efforts that you've made as part of the SPRP, especially since the strategic plan and the ACT Accelerator helped to strengthen the supply chain, notably in countries experiencing other issues, such as countries suffering from Ebola. The supply chain remains very limited in countries such as Palestine, and we do hope that efforts will be stepped up to allow us to address the various challenges that we face. And we do hope that donors will continue to provide their support as part of humanitarian assistance efforts. Thank you.
Thank you very much. As there are no further requests to take the floor, I shall hand back to the chair. Thank you.
Thank you very much, Moderator Fabia. I think we have some questions that Mike would like to take up, but we would be grateful if you'll brief in the intervention.
Yeah.
Thank you.
I'll try to be quite brief, and we may have to follow some individual follow-up documentation. Certainly, we'll be very happy to provide a comprehensive update on PPE, the O2 supply situation, and others. We increasingly working now with partners in the ACT Accelerator, looking at how we can scale up. For example, O2 is a huge issue. We've pilot tested sustainable supplies of O2 for many, many countries. We want to scale that up now. We're working with UNITAID and welcome on that. Similarly, we're having discussions on really evolving not only the availability of PPE, but the type and utility, wearability of PPE. We're doing that again within a consortium of partners, discussing how we can go even further to scale. So this isn't just a supply issue anymore. It's really around creating more sustainable mechanisms to guarantee supplies of the right equipment in the future. Similarly with diagnostics, working very closely with Peter Sands and with FIND on accelerating access and really scaling up access to newer diagnostics. Bruce may want to speak to that in the next session. A tremendous amount of work has been done to give operational support to vaccination readiness at country level. Kate O'Brien is here. Kate, you may want to speak to that. There's a huge amount of joint work going on in doing that. And with regard to operational costs, yes, some of the operational costs associated with delivering vaccine at country level is included within the current SPRPS plan, but certainly not all. This is really down to how do governments fund their national vaccine delivery plans, and some of that funding will obviously come from international partners through technical and operational support, but some of that funding will obviously, I think, is expected to come through the IFIs, World Bank and others, but I will leave that to Bruce and to Kate to explain, because it's not something I have complete sight on. Thank you to Germany and the UK, to the US, to Canada for mentioning the fact that you will look very seriously at the SPRP. We appreciate your previous support and count on that. With regard to the lessons learned from the last year and the funding side, I think Jane may wish to speak to this. The thing that really made it difficult last year for us was the heavy earmarking of a great deal of the money. So sometimes we were water everywhere without a drop to drink, because we had heavily earmarked money either on specific pillars or on specific countries, and that makes it very hard to move. So we would like to ask donors this year, if you could, if at all possible, make your funding as flexible as possible. But we understand those constraints. With regard to operational scaling up, I think we've known this for many years. We've learned 20 years ago that scaling up field response required a global outbreak alert and response network to be created. Scaling up medical and surgical support in the field required the emergency medical teams movement to grow. Scaling up our knowledge around influenza surveillance required the global influenza surveillance and response network made up of hundreds of labs around the world. So I do think, your point is really well made. WHO in itself is not about scaling up WHO, it's about scaling up WHO's capacity to act as the catalyst, the coordinator of that scale-up process. And I think Chanel referred to that in her analysis. So it's what we scale up at WHO, for what purpose. Scaling up our capacity to leverage global capacity is where we, I think, would see our direction in the future. And learning how to do that better with you and with our partners, be more predictable, higher levels of quality, higher levels of dependability in the system is something we really want to look at going forward. I'll ask Maria if we want to Tracy, you asked about an update on the summary report. I haven't got a date in my head, but I thought relatively soon. As soon as possible. We can give you a call, Tracy, and tell you what we think that means. But we are trying to just get the final touches to that. But imminent and as soon as possible. And we'll let you know as soon as we have a publication date. So I'll give the floor back to you, Jude. I don't know if Bruce or Kate just want to comment on the vaccination side or on the other issues.
Thank you, Mike. We're going to come to the vaccination section next, so let's deal with the questions there at that time. There was one specific question about the no-fault compensation mechanism from Zambia. Those costs are actually captured under the ACT Accelerator budget under the COVAX facility because that is paid for through a surcharge or a levy, rather, on the doses and the financed doses through the AMC mechanism. So that shows up in that budget. But we can come back to the specifics of that subsequently. And what I'm going to suggest is we're very close to having the no-fault compensation mechanism in place and announced, and we do a detailed briefing on that next week as it is so important to member states. So what we're going to do now in the FA section is just run.
Sorry, Bruce, can I just go across because we're quite finished before you go to that session? Because there's one thing I do have to say, and that is to Paul and the logisticians who work with him and his teams at the regional and country level, and your logisticians in the member states, and the real unseen heroes of this response, because our health workers have been celebrated, many others have been seen on TV day in, day out, but the people who've kept the supplies moving and the food chains moving, and the WFP colleagues as well, and the humanitarian operations, and the UN's the supply chain division in UNICEF, and all of the others. These are the unseen heroes of this response. And what was achieved was remarkable. It was painful and difficult, but it was remarkable. And we should celebrate, all of us, those unseen people who keep our logistics systems and keep our operation support moving. Never has it been more important right now, Bruce, than as we move towards the delivery of vaccines. So just to note, sometimes the heroes we have are never seen and never heard.
Thank you very much for those set of responses. I think we'll... Tim, may I invite Bruce to speak to the update on ACT strategy and budget? You have the floor.
Thanks so much, Jude, and thanks, Mike, for acknowledging again all the people that contribute to this gigantic response. What I'm going to do, member states, is just very briefly, and I'm going to leave these slides with you in the interest of time. Let's get to the vaccination issue. But as we updated you on the SPRP, and given obviously the integration of that with the bigger Act A overall strategy and budget and the overlap, we wanted to just say a few words where that stands. So as you are aware, the world's changing, the response is changing, even the virus is changing. And so the ACT Accelerator strategy is being updated to reflect that. It builds on the groundwork from last year. Of course, we're in a completely different situation. We have vaccines that can prevent the disease. We have tests now that can rapidly find it anywhere, and we can save lives using very affordable treatments. We also have mechanisms in place to ensure an equitable access, even if not fully where we want to be in that regard. I want to take a moment to recognize the contributors to the ACT Accelerator so far. $6 billion enabled the work I showed you on the previous slide across a broad range of contributors, and we have an additional commitments of nearly $4 billion that will help move that agenda forward. As we look forward, it's in the context of an evolving pandemic and an evolving virus, which you know well with respect to the variants. That leads us to the four, what we call integrated strategic priorities of 2021 for the accelerator. First, of course, the rapid scale-up and delivery of the vaccines. Secondly, you see here bolstering R&D, but also regulatory pathways, evaluation work to optimize the products. A lot of the products we have now, they serve the purpose, but they're difficult to use or not optimized. We have to optimize them for programmatic use and also for variants. As Mike highlights, and you, our member states, do as well, vaccines will not control this pandemic alone. We have to have the three robust lines of defense against virus and variants, and we need them everywhere. So the other big strategic priorities are about stimulating the rapid and effective uptake of the new rapid tests, some of the therapeutic options of PPE, and then having a pipeline to ensure LMICs in particular have access to those. That's reflected in the budget, which is part of the document. You've seen the budget gap before for 2021. It stands at 27.2 billion, broken down across the four strategic priorities, as you see highlighted here. But to deliver over 2 billion doses of vaccine, 900 million diagnostics, and then hundreds of therapeutic courses through a stronger system. The draft strategy has been under discussion with our Facilitation Council for nearly 2.5 weeks now, and there's been a lot of updates along the way. I've highlighted a few here. You now have, as you see in the upper left-hand side, detailed deliverables by agency, by cost, and by pillar, and by time. We also have now, as you see in the middle, fully aligned the work of WHO within the ACT Accelerator and with the SPRP, so we understand that overlap. Fully $1.2 billion of the SPRP work is directly part of what the ACT Accelerator is working toward. That's reflected now in both. And then you have the other elements where things have been strengthened over the last week. Now, in discussion with the Council chairs just over the last couple of days, the consultation period was to have ended on the strategy and budget on the 11th of February and then finalized to issue at the very shortly thereafter. But in discussion with some of the council members who wanted additional time to comment, the comment period has been extended out until the 22nd of February. Now, recognizing that others beyond the council and those who have seen it may like to comment, we've actually posted it on the web now 2 days ago. You can see the access point in the bottom left-hand side. And we'd welcome any feedback you might have. Ideally by Monday evening, that's short, but again, the big construct has been out there since the 2nd of February. But if there's any suggestion people have on how this could be strengthened, we'll be sure to have those incorporated as we work to finalize and publish the document for next Friday. Now, one of the biggest aspects of this, as I mentioned, we can take down the slides, please, is of course the work, and the first priority is to roll out the COVAX vaccines. What we'd like to do is update you next on some of the latest developments on that regard. So I'm going to hand over to Soumya Swaminathan, the Chief Scientist who leads that pillar of the ACT Accelerator work for WHO, to take us through some of the big developments this week, and then Kate O'Brien will update on some of the implications for us as we move forward. Can we take down the slide deck, please, and replace it with the one on the COVAX rollout? And then we're ready to go forward. Great. With that, perhaps I can hand over to Soumya to introduce the next short presentation.
Thank you, Bruce, and greetings to all the member states on the call. We'll quickly go through, we can go to the slides, just run you through some of the updates and what you could expect in the coming days. The next slide, please. As you are already probably aware that the WHO did the emergency use listing for the AstraZeneca vaccine, and this is from two sources, the Serum Institute of India as well as the SK Bio. Okay, we go back, I think, to the, can we start with the first slide? We just wait for that to come up. a lot has been happening in this space, and therefore there's always, we know that there'll be a lot of questions and queries and that you want to know where we are. We just wanted to give you an outline of all the different steps that are going on simultaneously. On the one hand, on the regulatory side, on the policy side, but also on the COVAX facility, where obviously we work with Gavi and UNICEF and PAHO to actually do the procurement and the shipments. So the emergency use listing for the AstraZeneca vaccine happened on Monday, the 15th. There are interim SAGE recommendations for the AstraZeneca vaccine. This is the third vaccine for which SAGE has made recommendations. And if we can go to the next slide, we are trying to accelerate the rollout of vaccines, obviously, so we can get to you as quickly as possible. It's, I think everybody knows that it's been over 2 months now since the first country started vaccinating. There have been almost 190 million vaccine doses distributed around the world using 8 different vaccines. But still there is inequity in the distribution. Over 80% of the doses have been administered in just 10 countries. The most widely used has been the Pfizer-BioNTech in terms of the number of countries and economies that are using it, followed by the AstraZeneca, Moderna, Sinopharm, and Gamaleya. Next slide, please. So Kate is going to run us through some of the next steps.
So just a reminder about the emergency use listing, there are now 3 products, the Pfizer product and 2 manufacturers of the AstraZeneca product that have received a WHO emergency use listing. This slide also shows you the indicative review timelines for additional products that are coming through the EUL process. Of course, there's no guarantee what the review will conclude, but this is what you can expect. And there is on the bottom of this slide a website that is updated regularly for the updates on all of these products. Next slide, please. On the SAGE recommendations of the AstraZeneca product, just really one slide on this. The first is, if we could go back 1 slide, please. The first is that the conclusion from SAGE was a demonstration of efficacy of 63% against symptomatic disease. The recommendation from SAGE is for immunization of persons 18 years and above without any upper age limit. The schedule is recommended as a 2-dose schedule, as with all of the products that have come through so far, and an interval of 8 to 12 weeks. The labeling for this product does allow for a 4-week interval, but there was quite strong evidence that with an increased interval between doses, there is enhanced immunogenicity and efficacy. There's really no data available on whether or not the product reduces or interrupts transmission or viral shedding. And we also have no data on the use of this product with any other product. There are no interchangeability of product data. So countries are recommended to use this vaccine according to the prioritization roadmap and the values framework as a guidance for the prioritization of target groups. Next slide, please. There are additional recommendations that are in the document, but I won't go into the details of those around specific population groups. I want to switch now to the issue of the variants, the viral variants. And on the left-hand upper side is just a map as of today on the distribution of countries where the variant that was first identified in the UK has been found. And in the bottom slide, the blue slide, is the distribution of countries in whom the variant that was first identified in South Africa has been found. Next slide, please. So those 2 maps don't express the fraction of the cases that are, or the breadth of the distribution of those variants in any individual country. We're watching very carefully the data that are coming out, both clinical data and laboratory data, according to each of the variants of concern and by each of the vaccine products, both authorized products and products that are still in clinical trials. The point of this slide is really just to show you that both by clinical data and lab data, we've got a lot of missing cells according to the different vaccines. So there's a lot of evidence yet to come on these products and variants. Next slide. So we're in a space of really having to work with imperfect and incomplete data, this slide does give you some of the details around the reduction in the lab neutralization of these viral variants. This slide is entirely about the B1351 variant, or the variant first identified in South Africa. And if you click one more time, I want to draw your attention. So if we could just, thank you, and once more. I want to draw your attention. There has been quite a bit of media and country discussion about the reduced efficacy against clinical disease for the AstraZeneca product from a small clinical trial in South Africa. This was not statistically significant. Nevertheless, there is concern about the measured value in that trial. This was only evaluated against mild and moderate disease because the people who were enrolled in the trial, there were no older adults in this trial, and there were no episodes of severe disease severe disease in the trial. So we don't have evidence around severe disease, and there is a plausible argument that for any of the vaccines, the efficacy against severe disease is greater than the efficacy against mild or moderate disease. You'll also note the Johnson & Johnson and the Novavax product do also have clinical efficacy data from South Africa at a time when the variant was widespread, and those also have reduced efficacy compared with the efficacy in a broader range of countries around the world. So this is probably the variant we're most concerned about, and are in a setting of very incomplete data at this point. Next slide. So just with respect to the AstraZeneca product and the variants of concern, the first point is that against the variant that was first identified in the UK, there is only a very limited reduction in the antibodies that neutralize the virus, and very small reduction in vaccine effectiveness against that variant. For the variant first identified in South Africa, the B1351, again, I'll just reinforce that we do have this one trial with a marked reduction in effectiveness, but only against mild and moderate disease. There is indirect evidence that is compatible with protection against severe disease. So WHO, through SAGE, has currently recommended the use of AstraZeneca product according to the prioritization roadmap, even if variants are present in a country, but that countries should conduct a benefit-risk assessment according to the local epidemiologic situation. And we really note that these are preliminary findings, and there's an urgent need for a coordinated approach for surveillance, evaluation of variants, and their potential impact on vaccine effectiveness. Next slide, please. This is just to highlight that there is a full toolbox of resources and training documents for countries to ready their preparations for the rollout of COVID vaccines. This is updated frequently. We have a full slide deck on this and a website where all of these resources are available to countries. And tens of thousands of individuals have now been trained through our training program on the deployment of COVID-19 vaccines. And more people are signing up and training through Open WHO. Next slide. I'll turn this over to Sumya just to finish up the last slide on the critical actions right now that are in front of what countries need to do. Over to you, Sumya.
So as the COVAX facility is placing the purchase orders, some have already been placed and more have been placed in the last couple of days. And we are still working to see that these doses start getting shipped out starting within the next 10 days. What is really going to be important in order for these doses to actually arrive and in countries is the following. We need the regulatory authorization in country for whichever vaccine you expect through the COVAX facility. Basically, a few countries that opted for the Pfizer vaccine and more broadly for the AZ vaccine, either coming from SII or from SK Bio. And since WHO has put both of these on both the Pfizer and the AZ vaccine have been listed under emergency use listing, countries which need any help or support in terms of dossiers, in terms of any other information, can work with us in order to get those regulatory authorizations as soon as possible, because vaccines cannot land unless that is done. Similarly, we will need the import licenses for those vaccine shipments. On the policy side, I think most countries do have a plan where the priority populations have been outlined and the way in which you will go about the vaccination. But of course, you also need to focus on the other elements, including the exact method of the vaccination program, have dry runs if necessary, ensure that the workforce is being trained, that there's adequate funding, that the cold chain is in place, and so on. In terms of the preparedness, in addition to the in-country preparedness, we would need you to execute the indemnity and liability agreements that should have already come to many of the countries from the COVAX facility. These then go back to the company, which will be shipping the doses. The company will sign it and then send it back to you for the agreement. So this again is very urgent. We know there are countries which need some support with creating a legal framework. A few countries need further legal support to do that, and we're trying to help them, but the majority of countries should be able to proceed. The language was shared several weeks ago, and I think there's been enough time to prepare for that. In terms of the vaccine volumes, you will receive the letters from the facility starting from tomorrow. So the first set of countries will get a letter with some dates of when you can expect the doses to start arriving, and these are the early doses that were announced some time ago for the month of February. Dr. Simao is here. She's in the middle of the allocation process for the doses that will be supplied from March to May, and you know that it goes through the algorithm for the allocation, followed by the Joint Allocation Task Force and the Independent Vaccine Allocation Group for validation. And on Monday, we should also have the allocation in place for the next 3 months, and then we will be informed about that. And as I mentioned, the purchase orders are getting ready from today onwards, and you should be getting letters specifically about the amount of doses you're going to get, and also the dates on which you might expect to start receiving them. Thank you very much. Back to you, John.
Sonia and Kate for that presentation, and of course to you as well, Bruce. I think we have a few minutes before we are asked to conclude our session for today. So I'll quickly go to the moderator and take up any questions that you have. And once again, urge that we'll be brief in our interventions. Thank you very much.
Thank you very much, Chair. We'll just give it a second to see whether anyone should wish to take the floor at this time. And with that, I have the pleasure of giving the floor to Sierra Leone, to be followed by Australia. Sierra Leone, you have the floor.
Thank you very much for this presentation. A question I want to ask on behalf of my country is, we are in a position to receive vaccines from different sources. And when you have multiple products, you know, it becomes a bit complicated. What advice is generally available for countries using products from different sources? Thank you.
Thank you. And now to Australia, to be followed by El Salvador. Australia, you have the floor.
Thanks very much, Flavia. Thank you to Dr. Burrell for the ACT-A update, and to Dr. Soinath and Dr. O'Brien for a helpful update on the vaccine rollout, particularly the data, or perhaps lack thereof, on the efficacy of the new products on the variants of concern. I hope I can take this opportunity to springboard off the advice that Dr. Ryan had given on the release of the summary and full scientific reports. If I can just project a little bit further beyond that, given that further studies have been recommended beyond the report, Is there any advice that you can point us to on what planning is underway to progress the next phase of scientific studies and how the international experts might be engaged? Thank you for your indulgence.
Thank you very much. And now to El Salvador. El Salvador, just confirming that you would still wish to take the floor. Dr. Duarte. And as it seems we're having some connection issues at this time, I shall hand back to the Secretariat for their responses. Thank you.
Thank you. I'll address the question from Sierra Leone on vaccines either of different products or the same product coming from different means. The first about if it's different products, again, I'd like to emphasize that the recommendation is that for an individual to receive in their 2 doses the same product. And that's only because we don't have information about what we would refer to as mix and match regimens, where you get one dose from one product and a second dose from another product. So with respect to the programmatic issues, the planning for having more than one product in the program would need to take into consideration how the supply will assure that individuals in either a geographic area or of a given priority strata will have the same product available in the program for the second dose, so that we avoid as much as possibly can be avoided having mix and match regimens until we have more clarity around the acceptability of doing mix and match. I think that's one of the biggest things. The second thing I would say is just around the compensation mechanism that Dr. Aylward mentioned as we went into this vaccine session. For vaccines that are being deployed by COVAX in AMC 92 countries, this compensation mechanism is available to all individuals who are receiving vaccine, and of course is a benefit to the countries as well, the governments. But what it does require is documentation of exactly which vaccine was received from which lot at which time, so it's clear and documented that it was a COVAX dose that was administered to the individual. So I think this is the second point that's extremely important for countries that are AMC countries, and maybe sourcing vaccines also outside of COVAX, is that very clear documentation of doses, lot numbers, and timing is extremely important in order for the compensation mechanism to be available to individuals should they have a rare, unusual, severe adverse event. So I'll turn over to Sumya now about the second question from Australia.
Yes, to address the very important question from Australia on what's next in terms of the variants, the different vaccines and how they can be deployed and what's going to be needed in terms of the research. I think there are several elements here that are important, and the WHO has set up a risk management framework to really look at all the different data that needs to be pooled in order to make decisions on vaccines, particularly with respect to variants. And so this includes surveillance, particularly genomic surveillance. We know that there are large parts of the world where there is insufficient genomic surveillance, and so it would be really good for countries that have those capacities and strengths to help others, perhaps in their neighborhood and in their region, to ramp up the capacity to do genomic surveillance, because I think this is going to be critical, and we're going to have a network like the influenza distress network that continuously monitors and updates the changes that are happening with COVID. Then there is the epidemiological information that needs to come in order for these decisions to be made, particularly in countries that have detected the variant but are wondering how to make these decisions. It's going to be important to use epidemiology and the clinical studies as well to inform us what these variants actually mean in terms of impact on transmission, clinical manifestations, as well as a response to vaccines. And Kate had shown a slide where we still have very limited data from the vaccines that are currently being deployed. on how efficacious they are when there is the infection with variants in the community. So we need not only the laboratory studies, but we also need the clinical effectiveness studies. And it's possible to have a good research program now. And that's the other thing we're working on. We've had rounds of consultations and are now developing a package of research protocols, from randomized clinical trials to cohort monitoring, many of them building on what's being done in influenza already, to observational studies, to safety studies and so on, in order to learn more as these vaccines are being deployed. And ultimately, all of this will come together at the WHO through a committee which will consider all of these and then make recommendations in the future for any strain changes that may be needed. As you know, many manufacturers are already working on the next generation of vaccines to address some of the variants that are currently have been detected and are of concern, the variants of concern. But again, that's going to need agreement between the regulatory agencies. And again, it's very good that regulatory agencies, the ICMRA, working with WHO, is already considering what are those critical elements that are going to be needed for regulatory agencies to make decisions on the new vaccines that are being developed now to address the variants issues. So again, there are lots of, there's a lot of work going on in this, but it is being coordinated. There are many things, and we can brief you on this in one of the upcoming. Thank you.
Thank you very much, Dr. Sumia, Dr. O'Brien, Dr. Bruce, and of course, Dr. Ryan and others who've made a presentation today. That brings us to the end of today's information session. We would, as the usual practice, upload the presentations for our member states who may wish to peruse further. And we would like to convey our deep appreciation to you. Director General, would you like to have any concluding remarks?
No, thank you so much to all member states who have joined today. I'm glad you raised the issue of vaccines. It's still a serious challenge. We're doing all our best to start rolling vaccines through the COVAX facility before the end of this month. That's in February. We're trying all our best, pushing through the manufacturers, plus also high-income countries to give donations. I will share with you one story. This is a good friend from a donor country, and I explained to him about the difficulties we're facing in rolling out vaccines through the COVAX facility. It's already now 2 months since some countries have started vaccination. And this friend of mine from a donor country said, but we have given you money, and why can't you start rolling out? And I said, yes, of course, there is money for COVAX, although still we will need more. But even with the money that's at hand, it's not, we're not buying, because when there is someone who is offering a better price, then the money at hand, may not help you to buy anything. So he said, "You're not serious." Then I said, "I'm serious, and that's exactly what's happening." I think without a strong political commitment from our member states to push and doing the right things, we will continue to face difficulties in sharing. And sharing is actually in the interest of the whole world. This virus cannot be stopped unless we aggressively attack the virus in all places. As you know, some variants are appearing, and some of them even more efficient than before the original virus. And to stop the variants, I think
doing whatever we can do everywhere, including sharing vaccines, is very important. So even money cannot change anything because of the story I told you. But still we're hopeful. We're going into the details of what the barriers are, the bottlenecks are, and we're trying to address the bottlenecks one by one, and hoping to start in February. Thank you.
Thank you very much, Director General. We would like to wish everyone a pleasant day. Please stay safe and welcome you back next week. Thank you.